for the Momento presentation.
Now I would like to invite Dr. Sunil Mittal for our next session. It is on psychological and mental health issues in obesity. And I would like to request Dr. N.K. Govil, Dr. B.K. Gupta and Ms. Damini to take the chairs for the session.
Hello. Mental health issues in obesity. I think most of the people are unaware. All major psychiatric disorders except the schizophrenia, depression, anxiety, panic attack, eating disorders, they are all common seen in obesity. And none other than Dr. Sunil Mittal is the best person to speak. And he is the director of Cosmos Group of Hospital. And I started in my practice in 91 with his center only. So it's a long association of 32 years. Come.
Good evening, everyone, and thank you, Dr. Gupta, for this introduction. He and I go back, like he said, more than 30 years. And it's been a pleasurable journey with him. I've just entered the last session when it was on, and it has been an enlightening experience because obesity is something that concerns everybody, all of us here. And here I am going to speak on the psychological and mental health issues in obesity. There could be many things I could cover, but given that it's just 15 minutes that I have, I'm going to look at some concepts, the neurobiology, because now we understand in terms of neuroscience, like Dr. B.K. Gupta was always emphasizing, we understand behavior in terms of neuroscience and then what's happening there. Firstly, I have no conflicts, potential or actual, except my conflict with my weight. I have no other conflicts. And the most of the information that I cite is in public domain. The comments and conclusions may be mine, but the data and the quotes and the views are available. And for anybody who's interested, I have a whole set of articles on this, and I can forward it to the organizers for anybody who would be interested. So obesity and mental health. Actually, obesity is as much a psychiatric disorder as it is a physical problem. My own tryst with this in form of a patient whom I was treating goes back to my residency days at the PGI Chandigarh, when a senior bureaucrat was referred because she had to undergo surgery and she was 124 kilograms. And the surgeon refused to operate. For those times, the gallbladder surgery had to be in laparotomy, and the surgeon refused to operate, she being a high risk. And then we worked through, like Dr. Dang was saying, an intensive program of not just with the dietetics, but also in behavior therapy, charting, monitoring, and so on, and brought her down to 80 kilograms when she underwent surgery. And then she maintained her weight between 80 and 90 with a great deal of, like I was hearing in the previous session, constant counseling, constant contact. So obesity, well, is a psychological issue because psychological issues can foreshadow, they can actually occur before obesity occurs. There could be psychological factors that go hand in hand when there is an attempt to control weight and there is a struggle to control weight. And psychological assessments are very important for weight management. Psychological interventions are very important for in a multidisciplinary approach, as it was emphasized, including when people are undergoing bariatric surgery, an assessment and an evaluation pre-surgery, post-surgery, maintaining motivation, otherwise people go back and put on weight, and that becomes important. So the current treatment strategies, of course, are dietary and lifestyle modification, behavioral therapy, pharmacology, the CB1 receptors, the cannabinoid 1 receptors. Rimonabant was a drug from Sanofi, which was pulled off the market because of its side effects, but it was effective. We were using it at that time. And of course, surgical interventions to bring down morbid obesity. The clinical outcomes remain mixed because it's highly resistant to treatment. People put on weight again, like many other disorders. And the outcome modifier, I repeat, the outcome modifier can be a good behavioral intervention plan. That is the one that actually modifies the outcome. Obesity is a complex interaction between genes, environment, and of course all the psychological experiences. And also there is increasing evidence that psychopathological factors contribute extensively to the development and maintenance of obesity and eating behavior. That's very important. And these areas represent possible targets for intervention, whether it's in terms of modification of behavior through pharmacology, through pharmacotherapeutic, or through behavioral modification techniques. So if you were to break it down, psychiatric risk factors in obesity, psychiatric sequelae of obesity, behavioral and psychological treatments for obesity, and the role of psychology in bariatric surgery. These are the 4 areas we can look at. The risk factors are depression, bipolar disorder, anxiety, eating disorders. BED is the binge eating disorder, which is a diagnosable condition. NES is the nighttime eating syndrome, which is separate from binge eating disorder, the nighttime eating syndrome which can occur. And of course, bulimia nervosa, in which not just there is binge eating, but there is also purging behavior. So there could be a compensatory purging behavior, over-exercising, vomiting, induced vomiting, and so on. Attention deficit hyperactivity disorder, because of a failure of executive functions and impulse control. We'll come to that, the neurobiology of that. Other impulse control disorders, and of course addictions. Addictions, food is also an addiction, addiction-prone behavior, and with other addictions there can be an increase in appetite, and there can be binge eating or otherwise increased calorie intake. The psychological sequelae, many studies have been done to look at this. A negative self-view which follows a low self-esteem. People consider people who are obese and can't lose weight as weak-willed, that they can't regulate their behavior. For us in psychiatry, willpower is emotional and behavioral self-regulation. That's what willpower is equal to, emotional and behavioral self-regulation. And if that by neurobiology is dysfunctional, it's a recipe for disaster. The failure to lose also weight, it also brings in discouraged behavior, frustration, hopelessness, and depression. Social discrimination, especially studies in children and adolescents have shown social discrimination because of cultural sets. They desire to lose weight, they desire to be lean and not be overweight. Quality of life gets impacted, depression and addiction, like I mentioned, can set in. The behavioral and psychological treatments, since they have been referred to, and we can, at any given day, we can have a separate workshop for people who are interested to actually look at what can be done. And there could be techniques and strategies which can be learned and acquired. Treating underlying psychiatric disorders, so a good diagnosis. People could be depressed, they could be anxious, they could be stress eating, they could have body image disturbances, and then set in a behavioral therapy or a cognitive therapy, or something called a cognitive behavioral hypnotherapy, CBHT. So you implant suggestions. So the classical model is that one behavior is linked to another. They get associated. You sit in front of the TV, you go for a film, you want to eat popcorn. That's conditioned. And you break those associations. The operant conditioning model is that you feel stressed, you feel anxious, you eat and you feel rewarded, you feel nice. So you cut down on the rewards, you cut down on the associations and build a behavioral therapy program. And then you have self-monitoring, charts, journals for self-monitoring, lifestyle guidance, stress management strategies, problem solving, everyday problem, interpersonal relationships, and so on, and cognitive restructuring. These are the sort of therapeutic tools that are employed, which my psychology colleagues do every day. And then, of course, in bariatric surgery, pre- and post-surgical counseling, treatment of psychiatric conditions. In case depression is not treated, binge eating is not treated, then people tend to put on weight. And psychological assessments and intervention areas include awareness of procedures and capacity. That's one. We often get patients who have to undergo bariatric surgery. They come in for evaluation and assessment. Their motivation for surgery, they may be strongly motivated. They may be wrongly motivated. Is it the right motivation? Well, I want to get married, so I want to go through surgery. Is it the right motivation? And then they go on and put on weight again, or they start eating in excess. They have problems, other health problems that can come up. Motivation for post-surgery compliance. That can be reinforced. Work on stresses and behaviors that may be barriers to lifestyle change, and so on. See, obesity, can I take 2 more minutes, please? Yep, thank you. Obesity and psychopathology is a bidirectional relationship. So obesity leading to psychopathology and psychopathology leading to obesity. I will just go through 3 charts to sum it up. So the pathway is a little complex. There are many brain hormones, neuroendocrine system involved. The common pathway is inflammation. There is sustained inflammation. Neuroendocrine system gets into disarray. There are endocrine disorders, metabolic dyshomeostasis, and all interact to cause neuroinflammation. There's a functional and histological imbalance between the microglial cells and astrocytes. This is all established. And this is what happens then. There is a cascading effect on the neurotransmitters, whether it's serotonin depletion or dopamine depletion, and impact on neuroplasticity, adverse impact on neuroplasticity, leading to something called neuroprogression, and then neurodegeneration, which is evident with actual scars, which are visible on high strength imaging studies. And then, of course, there is a clinical emergence of syndromes, right from depression, or even linked to Alzheimer's and other dementias that can follow obesity. Here is a chart which shows this. So the inflammatory markers, cytokines, the interleukin 1, interleukin 6, tumor necrosis factor, these get involved. There is also intestinal diabiosis. Now we know that the gut biome is under study, and that undergoes a change. And then, of course, causing this metabolism, dysendocrinism, and the multiple changes that follow in the neurobiological system of the person. And then, of course, the clinical syndromes. If you look at psychopathology to obesity pathway, well, result of eating disorders, which we have discussed, because of uncontrolled eating, emotional dysregulation. The common pathways are emotional dysregulation, executive dysfunction. Executive functions are being able to pay attention, being able to have cognitive inhibition, cognitive control, and cognitive fluency, as well as short-term working memory. All of them get impacted with obesity. And essentially due to ghrelin and leptin and other changes in hormones. So we have mood disorders and obesity as the causative agent, ADHD and obesity as the causative agent, and then is there a link? I will end with these 2 slides. An affective temperament of people who are dysthymic, have mood changes, are irritable, they are anxious, they have executive dysfunction problems, they have impulsivity, emotional dysregulation, their motivation remains poor, and eating and food addictions follow. Here is a chart that explains this. Neurodevelopmental features, cyclothymic, that is a mood instability sort of characteristic, leading to mood disorders, ADHD, eating disorders, and obesity. And then a cycle sets. There is a behavioral dysfunction resulting in weight gain, which causes neurobiological alterations, which causes neuropsychiatric dysfunction like depression. And there is further behavioral dysfunction. And this is a vicious cycle that sets in. To break it in actually requires, as is pointed out, intense therapeutic work with a multidisciplinary team. Here is since there is going to be another presentation on metabolic disorder, this is the sort of neuroendocrinal chart which shows where all the changes that occur with obesity, with psychiatric disorders to cause a metabolic syndrome. And since we don't have time, we can't go into this. So I'll end here by saying psychiatric obesity, in substantial cases, with the emotional eating, cyclothymic actions, personality, dysexecutive control, and other mood and behavior regulating dysfunction.
Thank you, Dr. Mittal. I think we need to stop here.
Yes, I'm going to end.
We know that there is a complex relationship between obesity and psychiatric disorders.
My last sentence, sir. So my last sentence. And here we are then, underlying is the psychosocial environment and the genes. And today we have gene-based diet planning and therapy which is available. Thank you very much.
Thank you, Dr. Mittal, for giving such a wonderful insight into what are the psychological aspects that go into obesity. And I think as a psychologist, I would just like to summarize by adding a little to what you have said, that when we are looking at obesity, we need to take in a more holistic approach now rather than thinking of it as just one physical or a medical problem. It's important to look at it as, take a multidisciplinary approach, basically, where we are looking at the psychological factors that go into obesity, the nutritional factors, the lifestyle, what is it that, we can do to be able to support the patient or the person better. Because it's not just one, intervention that is going to work. It's going to be a combination of a lot of things. And as the medical community, psychological community, we all need to sort of work together to now start putting those into practice. Thank you.
Yeah, Dr. Lauti.
Sir.
In day-to-day practice, it is very difficult to involve the psychiatrist or send a patient to the psychiatrist, because this obesity treatment is so complex, and obesity treatment actually takes a back seat in our practice. We first try to address diabetes, fatty liver, or so many other things. So obesity and comes to our psychiatry comes to our mind at a later stage. So one, I wanted to ask you, in which situation you can be most helpful, and second, there is increasing screen time amongst school children. Do we have a pharmacotherapeutic approach towards that?
Thank you, sir, for these two questions. These are very important questions, because if obesity treatment takes a back seat, psychiatric screening for other disorders takes even a backward seat. So what I would suggest is one could get familiar with a 10-question questionnaire, which I can provide, which can help you screen for presence of psychiatric disorder. It's in public domain. It's not, and it's a well-established questionnaire, self-administered by the patient, and wherever you feel you can administer it, I'll send it across. And then, in case people turn out to have a diagnosable condition, either you could go ahead and treat, and if you would like, get in touch with a psychiatric colleague who can then help you. If anybody would like, we can extend support in terms of what could be done in your clinic. What could be done right there, because a patient will not come to a psychiatrist. If you refer 10, only 1 will turn up, 9 won't. So best is to treat there. And this can be worked out. So that's one, sir. Second is increasing screen time is a problem. And we know this, with increasing screen time, there is a suppression of melatonin, there is a disturbance in nocturnal behavior, there's a disturbance in circadian rhythms, there's a disturbance in mood changes. In fact, the evolutionary biologists believe that probably the advent of artificial light and now screens has actually caused a lot of neuropsychiatric problems because of disruption in the circadian rhythms. And all of us are actually victims of this, including young ones. There is still no pharmacological intervention. The one that we prefer to use is melatonin, along with sleep hygiene. So psychotherapeutic work with melatonin, screen for any other presence. There could be a low dose of if there is any mild anxiety or depression, then some sedative antidepressant could be used. But this specifically none, except melatonin.
Thank you, Dr. Mittal, for your
Thank
enlightening
you.
presentation. I think everyone has enjoyed. Thank you.
Thank you very much.
Thank you, Dr. Sunil.
And thank you for your patience. Thank you.
Can I make one point, please, Dr. Mittal? I'm Dr. Moda. I have one, the way we are not taught psychiatry well in our MBBS curriculum, the same is happening nowadays with today's children. This, instead of patient visiting our clinics, I think we as doctors, especially the psychologists and psychiatrists, should be probably counseling children in their schools. And then probably their behavioral pattern will change. If they come to my clinic and then I send them to you.
Certainly, sir. And most psychiatrists, we also run programs in schools for counseling there.
Yes, I think it should be incorporated in the school curriculum, as Dr. Deepak was saying. This is my request.
Thank you. Thank you very much.
Thank you, Dr. Sunil.